Assalamu alaikum everyone. My name is Rula, and today I'll be giving you the MSI skin disorders crash course. We're going to be covering all of dermatopath, all of derma, and one immuno lecture that's relevant. All of dermatopath is in blue, all of derma is in hot pink. Immuno lectures or stuff that I got from immuno tends to be like baby pink or lavender. Okay. Another thing I want to say, I went over Dr. Abrar's slides, I went over Dr. Ahlam's slides, I went over all the derma lectures you guys had, and there should be, okay, a star over here, or there is a star over here, um, that indicates stuff that has been asked about before. So let's get started. Now, for this is just like a general overview of the skin. You have four layers: stratum corneum, which is dead cells with keratin. If you have dry skin and you do this, okay, and you see stuff flaking out, that's basically this your stratum corneum. Okay, it's keratinocytes that have proliferated up to the top from the stratum basale. Okay, this. Okay, they matured, they lost their nuclei, and they just fall off. Stratum spinosum is where you're going to find the immunocells that we're going to be talking about. So just keep that in mind. There's not much to this slide. Just wanted to mention, no, this is what's happening. Okay, so some basic info about the skin is that from the stratum corneum to the stratum basale is the epidermis. The anything below is called the dermis. Now, there's something called the melanocytes. It creates melanin. It's in the name. And their embryological origin is the neurocrest. This is important. The fact that its embryological origin is neurocrest, just note this, okay? Now, people of darker skin tones, they have more melanin, okay? And that puts them at an advantage because they're less likely to develop a thing called melanoma. Melanoma is just like skin cancer, okay? It's kind of like inbuilt UV protection or SPF factor or whatever you want to call it, okay? There's no nuclei in the corneal layer. As I mentioned before, keratinocytes are maturing. Okay, so they die off at the start. If there is nuclei, it's something called perikeratosis. Now, this perikeratosis, I'll show you what the slides look like later on. There's something called Burkill cells. Again, this is covered in histo, but it was mentioned a few times, so I made sure to include it. Merkel cells are soft, tactile sensation in the dermis. So, like, the best way I can describe it is that if you guys had a roll of tape, okay, and you're trying to find the edge for it so that you can pull out the tape, I feel like that's where Merkel cells are working out. Now, melanocytes, they communicate through something called melanosomes, okay? So this is the melanocyte, okay? Melanosomes are these, they communicate with each other, okay? One melanocyte creates 36 keratinocytes. Different body parts have different concentrations of melanin. So think skin folds, for example, elbows, okay? Your axilla, your groin, they tend to be darker in color. That's why there's different concentrations of melanin in them. There's not much to it. Just remember the information as is. Okay. This is the whole bulk of immuno. Okay. It's three main cells. I thought and know. Okay, the best way I can explain this is with Powerpuff Girls. If you guys have another mnemonic that you would like to think about, I don't know, Avengers or something. I don't know. Mom. You have Langerhans cells, resident memory T cells, and gamma delta T cells. Now, usually in the body, you have alpha beta T cells. In the skin specifically, you have something called gamma delta T cells. Okay. I thought, as I was doing your crash course, each cell in some way was linked to the characters of the Powerpuff Girls. Don't ask why. Just know it as is. It will help you. I promise. Now, Langerhans cells, they have dendritic characteristics, i.e., macrophages. They have like weird, what do you call them? Thingies. Okay, like tentacles. Okay. The way I remember in Langerhans cells remind me of tentacles. Bubbles had Tashi, that was an octopus. Mammalina. Okay. They're macrophage derived and dendritic cell characteristics. They're class 2, she has two pigtails, so class 2, MHC, and they have lectin, Langren, and Berbic granules. Do I know what they do? Do you guys need to know what they do? I don't think so. Okay. They take the antigen, so if you're exposed to a different bacteria, they take the antigen down to the dermal layer, so below the stratum basale. They go to this draining lymphatics nearby. They tell the naive T cell, they're like, hey, we found something. I don't know, it looks important. You should look at it. Okay. This causes inflammation, okay, which is harmful, or regulatory T cells start working, which is not harmful. Okay. They just keep that in mind. They're like, okay, this antigen exists. They also promote Th1, Th2, and Th17. It When these cells are promoted, it gives you inflammation or a type 1 hypersensitivity response. Um, the the cells I'm talking about right now, they respond better to lipid antigens. So just keep that in mind. In the lecture, it was like, oh, they mainly respond to lipid antigens, just lipid antigens, okay? And one thing, Langerhans cells, if they're in the dermis, it's a dendrocyte, okay? It's not a Langerhans cell. It needs to be in the epidermis, okay, the stratum spinosum, for it to be called Langerhans cells, okay? The next thing is gamma delta T cells. It has a gamma delta heterodimer. It's 5% of the T cells that are made. It's barrier immunity, so think mucosal tissue, the skin, the gut, the urogenital tract. The way this cell reminds me of Buttercup is the fact that she's very rash in the show. She's just punching whatever is in her face. Gamma delta T cells are almost the same. Okay. They express CD8, antigen class 1, cytotoxic mechanisms, or antibody-dependent cell toxicity. This not really. Again, added for completion. CD16 for FC portion, they inject granzyme and lysosome. So they're not really differentiating and becoming like, okay, I'm going to make this specific antibody. No, they're just trying to kill whatever is there. Okay. TNF, tumor necrosis factor related death receptors, they cause apoptosis. TGF beta to repair damaged tissue. Okay. There are stress-related proteins involved in this, lipid-based. Okay. Lipid-based, as mentioned before. I want to say one thing for immuno is that they're not really that focused. However, I felt bad in just focusing on whatever was asked about before. So a lot of this is added for completion's sake. Resident memory T cells, okay? These are calm, like Blossom, okay? They're wise in some way, but they still attack, okay? CD8 positive cytotoxic T cells, herpes virus in the skin after resolution of infection. These help the resident memory T cells reminds of it, I think. I don't know. No. They're recognized by expression of CD69. Okay, so if you wanted to take a sample from the skin and you're like, okay, are there any resident memory T cells? You use a CD69 what is it? Dye, I guess. Okay. It's also a marker for B cells, T cells, NK cells, and macrophages. They release interleukin 7 and interleukin 15. Most of this is not really important, but keep it in the back of your head. Cell factors in the dermis for the innate, okay, for the innate response, DCS, macrophages, natural killer T cells. They're hybrids between classical lymphoid T cells and NK cells. They're stress-related proteins. They recognize stress-related proteins and lipid antigens. Plasmacyte dendritic cells secrete interferon alpha. Mast cells are also present. Mast cells are important for eczema and dermatitis. Innate lymphoid cells, fixed lymphocyte, again, don't need this. Type 1 hypersensitivity, type 1 hypersensitivity response, ASH. Cell factors in the dermis, adaptive, Th1, Th2, Th17, Tregs, CTLs, alpha, beta, and gamma, delta, T cells, B cells. Listen, when I was doing MSI, I didn't study the immuno lecture, so don't take my advice though. Don't take my advice. I'm still explaining it. Influences of the skin microbiota is that there is the concept behind this is that there are resident bacteria on your skin. Okay, each person has different flora, and what happens, why this is important actually, is that if there's a disruption of some sort, you will get skin infections. Okay, the skin infections will be covered later, but the idea is that you have good bacteria to some degree. You have bacteria on your skin. They're there so that other bacteria, okay, doesn't come and invade your skin and causes you problems. Okay, you have the staph epidermidis, you have cutaneous something, and you have another one mentioned later. Okay, skin microbiota release defensins and cathelids, induce keratinocytes to release TGF beta, FOXP3 is activated, peripheral tolerance. Oh, it's the same idea I was talking about just a second ago, but in fancier words. Staph epidermidis releases lipoic acid. It's selective for keratinocytes, DLR3, and it inhibits inflammatory cytokine release. Okay, so this cycle, what's talking about, you have staph epidermidis. We're cool with her. Okay, it produces lipoic acid, which is in a way, think about it as a growth factor for keratinocytes. Keratinocytes proliferate, which is good. We need them to proliferate. Otherwise, our skin would be very, what do you call it? Like very sensitive. Okay. Dysbiosis is the change of skin microbiota, dermatitis, or psoriasis. Okay. This is what happens for these diseases. Again, keep it in the back of your head. Okay. The reason they inhibit staph epidermis inhibits inflammatory cytokine release is because otherwise you're going to be like constantly trying to fight with bacteria that's technically not doing anything harmful. Okay, if it's there and there's no reaction to the skin, you're fine. Now, skin appendages is like, other than the layers I was talking about and some of the immunocells that were here and there, there's something called the hair follicle, sweat glands. These, both of them lack stratum corneum. And the reason for it is because, okay, you have the skin, okay, and then you have stuff going outside of the skin. You can't have something that's blocking it, okay, logically. So there is no stratum corneum, okay? Hair follicles express fast ligand, but lack class 2 MHC expression. So therefore, T cells can't be activated. When T cells are activated, they attack the hair follicles, which causes a type of alopecia. Okay, the extracellular matrix around has regulatory T cells to prevent inappropriate activation of T cells. Okay, so T cell, they okay, they don't want to cause problems. You stay in your lane, I stay in my lane, we're good. Activation of the cutaneous response. This is important. I put it here. They went into too much depth in the in your lecture. Not too much depth, but it was a bit confusing. So this is the best way I could have simplified it. Okay, so you have bacteria coming from God knows where. The keratinocytes are like, okay, I'm not used to this. I'm gonna release some AMPs. Okay, these AMPs induce the release of NFK beta and release TNF alpha, tumor necrosis factor alpha, interleukin 1, interleukin 6. Okay. This later on causes the activation of Langerhans cells. Okay. You remember bubbles? Okay. That. They take up antigens and then they present it to the naive T cells, Th1, Th2, and Th17. They're like, okay, I found this, I give it to you. Okay. Then you have circulating effector T cell. They go to the T cells and the lymph nodes. Okay. The T cells, they start to mature. They're like, okay, this is a threat. I need to prepare. Okay. There will be a chemotactic movement to skin sites. So there will be more cells that are being involved and brought into wherever the infection is to prevent it. This is the recruitment of T cells to skin. There's tissue injury. Interleukin 22 repair the damaged skin layer. I think this is important. I don't know. I'm not Dr. Garland. Another thing you need to keep in mind is that two pain receptors, TRPV1 and NaV1, they're sensory neurons. We'll take more about it in neuro, but just keep it just know في sensory neurons إنه there are sensory neurons, okay? And when they sense there is a cut or there is pain somewhere in the skin, they tell the T cells, they're like, okay, يلا تعالوا اشتغل. Let's get to work, okay? They produce CGRP, calcitonin gene-related peptide, okay? And they activate nearby dendritic cells. The dendritic cells release interleukin 23. Interleukin 23 acts on gamma delta T cell. And this T cell works on Th17. Th17 works on neutrophils. Okay, Th17 releases interleukin 17. Okay, there's guys. I don't know how much easier I can make this صراحة. بس يعني just know it exists. Just know this exists. If they're gonna ask you something, I feel like they would ask you this. Okay, if they want to be mean to you, this is really unlikely. Okay, cells in the skins. You have the squamous epithelial cells, keratinocytes, they make keratin, duh. And cytokines to regulate other epidermal cells, not so duh. Okay, melanocytes for melanin, UV protection, mentioned earlier, dendritic cells, Langerhans, antigen-presenting cells, and dendrocytes in the dermis. Lymphocytes, cutaneous lymphocyte-associated antigen, innate and adaptive immune systems. Innate and adaptive is mainly in the dermis. Okay, you don't need to know the process. Okay, just know that the three main cells I feel like are the most important and what they do. Cutaneous T cells, there's CD4 and CD8 populations, CD4 positive and CD8 positive populations. There's also neural end organs and axonal processes, Merkin cells, and neurogranular. Yeah. Adnexal components here with the skin appendages, sweat glands, and hair follicles. Okay, type 4 hypersensitivity, allergic reaction of some sort. Okay, according to Abrar, this picture is really important. This is just showing you what's actually happening. Now you have the non-activated, okay, which is your normal skin. You have your Langerhans cell in the epidermis. You have your memory T cell, CLA, which is cutaneous lymphocytic antigen, dermal dendritic cell, and dermal fibroblast, granulocyte, monocyte. Okay. Now what happens in the innate? Okay, you have the antigen. Body's like, okay, what the hell is this? Okay, activated Langerhans cells. It sees it. It's like, okay, I'm gonna take this. I'll present it. Okay. Dendritic cells become active, fibroblasts become active. The reason fibroblasts become active is because you need to repair the skin because you can't always have a cut. Otherwise, you're going to get sepsis and other nasty infections. Okay. These also migrate to the local lymph node, okay, so that they tell other cells, like, hey, let's get to work. Like, this is a new antigen. We don't know what's going on. Granulocytes, monocytes, they also come. They help. They help with the what do you call it, therapy? They help with the new antigen because they're like buttercup. They're crazy. Okay? Adaptive is when oh, this antigen, I've seen it before. I know what to do now. Okay. Think innate as unprepared, adaptive as oh, I'm prepared. I know what I'm gonna do. Okay. So you have the antigen, you have the activated Langerhans cells, the CLA positive T cells, the cutaneous lymphocytic antigen T cells. They go to the Langerhans cells, they tell what to do. Okay. More T cells are also recruited to help fight the infection. That's it, wallah. Okay. Mentioned here. Okay. Effective and memory lymphocytes, so lymph nodes and all of that jazz. Okay. Now we actually get into dermatopaths. Okay. I hate immuno, and I'm very vocal about me hating immuno. Okay. So you have the microscopic terms, the bigger lesions that you would see, and you have something called the microscopic, which is stuff you would see under a pathology slide. Okay. You have a macule, you have a papule, you have a nodule, you have a patch, and you have a plaque. For these are basically recall, okay? And the way you differentiate is with the size and the description they're giving you. These are mainly important in pro, I believe, and there's something else that's also important, but this was asked about before, so I'm just letting you guys know, and this was asked, okay? You have a macule, it's less than 5 millimeters, okay, and it's flat, okay? A patch is basically the same thing, but it's greater than 5 millimeters. You have a papule, okay, and it's a dome. It could be a dome of anything, okay, and it's below the stratum basal, I believe, okay, and it's less than 5 millimeters. You have a nodule, okay, and it's greater than 5 millimeters. You have a plaque, okay, that's also greater than 5 millimeters, okay. Did I mention that nodule was more than 5 millimeters? I think so, okay. Just know, in a papule, less than 5, nodule, more than 5. I don't know how else to feed you the information. There's always so much mnemonics and stuff I can tell you. Just keep practicing. You guys will get the hang of it. Macule is mini, so less than 5 mm. Papule sounds like macule, less than 5 mm. Patch, like, you know the patches that you stick on the clothes? Kind of like that. Elevated lesion, nodule, plaque. It's a sphere. Come on. That was from Dr. Abra's slides. I just added the schematics because I found them like the visualization of what was mentioned is better. This is what they look like on actual skin. The bottom left is a nodule, so this is a nodule. This is a patch. Okay, macules and patch. The small one would be this one. Okay, I'm pointing with it with the arrow. The small one would be a macule, the bigger ones would be a patch. Plaques, okay, patches. Now, this is where it gets a bit gnarly. You have something called the vesicle, okay, and it's fluid. It's a fluid-filled thing, okay, and it's less than 5 millimeters. Bulla, on the other hand, are fluid-filled things that's greater than 5 millimeters. A bulla is also called a blister. I don't know if you guys burnt your hand with something and you get like a balloon. That's what a bulla is, okay? Pustules, in the name, it's pus-filled, okay? Pus is like dead neutrophils, accumulation of dead neutrophils and other immune cells or cells in general. This is what a pustule is. Okay. So this is what they look like. This is what the bullous looks like. This is tiny, tiny pustules. Okay, and it's impetigo. It's caused by Staph aureus is the main one, I believe, but there is some streptococcal involvement. We'll talk about this later. Don't stress. I got you. Okay. Then you have the itchy stuff. Okay. You have something called a wheal. Okay. And it's itchy elevated lesion with blanching. Ooh, I missed an etch. Okay. Blanching and erythema. Blanching is you take a glass. Okay. You put it. Okay. If it goes away, it goes away. And then you take it back, it comes back. That's what blanching is. Okay. Scale. It's like a dry piece of skin. Okay. Imperfect cornification, which is keratinization. When your skin is dry, you put moisturizer. A key word is basket weave cornification. It's mentioned in another disease. We'll go over it, don't worry. Lesiontification, thick and rough skin with prominent marking because of repeated itching. This, the best way I can link it, is when I get a mosquito bite and the mosquito bite is not going away, so I'm just itching, okay, constantly. I get lesiontification. This is exfoliation, traumatic lesion due to the breakage of the epidermis, scraped knee, or extreme itching. Okay, it's just the dermis is gone. Okay, you literally scraped a part of your dermis where you reach the inner part of your skin. Onycholysis, the separation of the nail plate from the nail bed. This is very common with for people with psoriasis. Microscopic terms, the tiny ones, the histocytes. You have erosion. Okay, it's discontinuity of the skin, incomplete loss of epidermis. The basement membrane is intact. Okay. Um, Ulceration is discontinuity of the skin, complete loss of the epidermis. Okay, we're going deep, deep in. Okay, and a bit of the dermis, even fat. Even fat is in the subcutaneous tissue. Hydropic swelling, which is ballooning. There's edema of the keratinocytes. You can see over here, this is not an accumulation of fat. Fat would be under, okay? And you can tell, the keratinocytes are big and poofy and round, okay? Exocytosis is inflammatory cells or RBCs in the epidermis, okay? So they should usually be here, but they're here for some reason. Can you, okay? That looks like a neutrophil to me. That looks like a monocyte to me. Those look like stuff I've taken in first year. Okay. Acantholysis is the loss of intracellular cohesion between keratinocytes. Okay, this is where the Bullous disorder lecture comes into play. This is really important. Okay, just know there's separation because there's no desmosomes. And if you guys remember anything from FND, اللي هو desmosomes or hemidesmosomes, they basically are the glue, or not the glue, the nails, okay, of the cells to keep everything together. Okay, and you would have a mutation in the coding of the gene for this, or there would be an infection and it would cause a loss of these desmosomes or hemidesmosomes, the nails of the skin, which is why you have bully. Okay. Acanthosis is diffuse epidermal hyperplasia. Okay. There's an increase in the squamous cells. Okay. You can see like this is normal, this is طبيعي, this is not طبيعي, this is not normal. Okay. Increased keratinocytes, increased squamous cells. There would be like thick keratin at the top. That's all. This keratosis is abnormal premature keratinization below stratum granulosum. We said the layers, okay? The keratinocytes are not maturing, okay? And you need them, okay? There is a specific, what do you call it? Evolution cycle for the keratinocytes. However, they're not evolving the way they should be. They're not maturing the way they should be. That causes this keratosis. Hyperkeratosis is the thickening of stratum corneum. Okay. See, this is really thick, specifically in this part. Okay. The quality of keratin is not good. But it is helpful for the palms of your hands and the soles of the feet. Okay. And if you guys notice this, but people who walk around barefoot, especially on hard ground, the soles of their feet, they become thicker, okay? Or if you're a person who goes to the gym a lot, you would see like scales over here. Calluses is the word I was looking for. The calluses over here, they're thicker, okay? Because of hyperkeratosis. Okay, hypergranulosis, hyperplasia of stratum granulosum because of a lot of rubbing. This is the dead keratinocytes. Okay, this is the granulosum layer. Okay. Parakeratosis, I mentioned before, there's still a nuclei in the dead, okay, keratinocytes. Okay, and this is not good. Okay, this is what it looks like. You can see like this is where it should be. This is where the stratum granulosum is. Okay, and you still see nuclei. This is not normal. This should not happen. Spongiosis is the intracellular edema of the epidermis, and it's similar to swelling of the keratinocytes, which is what was it? Hydropic swelling. Hypergranulosis, no, where was it? Spongiosis, intracellular edema of the epidermis, which is similar to hydropic swelling. I'm pretty sure it's the same picture, Tara. Vascularization is vacuoles, okay, and the basal cell, basement zone, okay, and this is for HPV. So think warts, again, covered later, but this is what it looks like. Keep it in the back of your head. Wasn't really asked. Where was it? Why is this not working? Oh. Okay. Now, lentiginous, which is a linear pattern melanocyte proliferation in the epidermal basal layer. Okay. you would see um this again, not normal. Okay, you would see this as well. This is specifically, actually, wait, no, this is normal. This is not normal. Okay, over here you would see melanocytes. There are too much of them when there shouldn't be. Okay, the way I think of it is ants. Okay, they're dark. Okay, they're brown and they remind me of melanocytes, and it's just a line of them. Okay. Papillomatosis is a surface elevation caused by hyperplasia of contiguous dermal papillae. Okay. Um, yeah, they remind me of salad fingers. Again, keep it in the back of your head. This is the basics. Okay. This is in the intro lecture. This is what you guys need to know. We'll get into some good stuff now. Okay. We're going to talk about acute and chronic dermatosis. Okay, the acute lesions is anything that happens from days to weeks, and the chronic lesions is anything that happens from months to years. Okay, so think inflammation, edema, different levels of injury. You have your urticaria, hives. Okay, so if someone eats something that they're allergic to, this is what happens to them. Eczema and erythema multiforme. Chronic lesions like psoriasis. Kim Kardashian has psoriasis. I don't know why I know this. I just know she does. And you have seborrheic dermatitis and lichen planus. Okay. Acute inflammatory dermatosis. Okay. The first one is urticaria. Sorry. The first one is urticaria, which is hives. One thing to keep in mind is that you get your the antigen that the person is allergic to. Okay, and then you have 24 hours. Okay, it should reside within 24 hours. If it's persistent after 24 hours, it's not your urticaria anymore. Okay, it's a type 4 hypersensitivity reaction, mast cell degranulation. Okay, so histamines and all that jazz. You have angioedema, okay, and edema of the cells themselves, small pruritic papules to large edematous plaques. Eosinophils and the dermis is affected as well. Okay, these are the examples of urticaria and how it presents. Okay, these are more examples. This was taken from your derma lecture. These are more examples. Okay. Type 1 hypersensitivity response. This wasn't really covered in immuno. I believe it was covered in derma. Okay, could be wrong, but it was covered somewhere, and the doctor did say, "Oh, I would like this would be a good question to have." So your mast cells, they degranulate because there's an antigen-antibody interaction, and the body's like, okay, what the hell is this? What am I supposed to do with this? I don't know how to deal with this. Okay. They release histamine, proteases, and chemotactic factors, arachidonic acid, and PAF production. Prostaglandins and leukotrienes are produced, okay, which causes vasodilation, vascular leakage, and smooth muscle spasm. Okay. This is the butter of the hadith of what the doctor was talking about. Do I think you need to know this much detail? I don't think so. And plus, you've already most likely covered it in POD. Again, keep it in the back of your head. Late response, leukocytes are involved, okay, and there will be epithelial damage and bronchospasm. The best way I can describe it, I can give you a scenario about this, is someone with a severe peanut allergy or a shrimp allergy. And some people, Allah yahmihum, if you take like a nut of any sort, and you put it on their skin, okay, they would get an immediate allergic reaction. But to imagine, someone is, what do you call it? Someone in justice, okay? It's just a mess all around. They need EpiPens. They would need EpiPens. They need to be taken to an emergency department just to make sure they're fine. Now, there's a lot of pathogenesis involved with this. Okay, like there's different things about it. Now, mast cell dependent, IgE dependent reactions is the scenario I was talking about just now. Okay, so pollens, foods, and drugs. Okay, they just degranulate. They just get stressed and they just break down. They're like, okay, this is all I have. Just leave me alone. The mast cell dependent IgE independent. Okay, so IgE ما له دخل بالموضوع. Okay, so there isn't like an antigen involved. Okay, um, this is mainly because of drugs like opioids and antibiotics or contrast material. The mast cell, they just degranulate without IgE. Okay, I am not sure about the actual like proper philosophy of it. Just know this is what happens. Mast cell independent, IgE independent. Okay, so mast cell is fine, no IgE involved. It's because the aspirin suppresses prostaglandin synthesis, and prostaglandins, they just kind of they tell the body like, oh, everything is fine, you don't need to stress. Okay. Complement mediated is something called hereditary angioneurotic edema due to a deficiency in C1 esterase inhibitor, C3 to C3A production, mast cell degranulation. Okay. This one, the mast cell are degranulating. It's just there isn't in the complement cascade, I don't know if you guys remember it. In the complement cascade, there's C1, C2, C3, and all of that. If the C1 inhibitor, okay, is not there, the C1 will start attaching, and then the complement cascade will go on, and then the mast cell will just degranulate. Okay. Interleukin 4 and interleukin 13 are important for this. Okay. So again, keep it in mind. Okay, these are schematics of what I was just explaining. Histamine, tumor necrosis factor alpha, proteases, heparin, prostaglandins, leukotrienes, interleukin over hours, cytokine production, interleukin 4, interleukin 13. H1 and H2 receptors act, causes itching, vasodilation, and increased vessel permeability. There would be some edema. I don't know if you guys had an allergic reaction before, but there would be like some sort of edema involved. This is just a schematic of what I was of what what am I saying? Okay. This is a schematic drawing of the IgE dependent to mast cell degranulation كل هالحركات هي. I added for completion. If my explanation was confusing, just go over the pictures very quickly. It's not that difficult. You guys have taken this before. All of this it. Okay. Eczema, atopic dermatitis. You most likely have met someone with eczema. Okay. Sorry, guys. Okay. They are red papulovascular oozing encrusted lesions. You can see here. Okay. This is in acute. Okay. Or plaques, acanthosis, and hyperkeratosis. Okay. Which is this. Okay. Which is more chronic. Okay. There's also another name for it, which is atopic dermatitis or allergic contact dermatitis. They're kind of, the way I think about them is that they're all kind of in the same category, but it's just that allergic contact dermatitis is in acute episodes. Okay. I don't know if you guys keep up with this kind of stuff, but I do for some reason. And there is a specific chemical in nail polish, okay, that's giving people dermatitis, okay? And the EU had to put a ban on it, okay? The reason for that is because it was causing allergic contact dermatitis, okay? And regarding this substance, it's more of when the polish itself is hitting your skin a lot, okay, and you feel like, oh, this is itchy, just be careful, just watch out. This happens in gel polishes, by the way, not the normal polish you get from the pharmacy. Okay. This is there's a risk of bacterial superinfection, which is empathogenization. Impetigo, we'll go over it later. It's a type 1 hypersensitivity response. Asthma and allergic rhinitis are involved with this. So just like, I don't know, a constant allergic response in a way. There is a small pathogenesis that you need to keep in mind, which is a filaggrin defective filaggrin, one of the trying to find the word. One of the proteins that keep cells together, okay, is defective, so it can't bind the keratin fibers in the stratum corneum, upper cell, so it just flakes off. Okay. These are chronic. And for eczema, they're usually found in flexor regions. Okay, so just keep that in mind. This is what looks like this. These are the common sites in a baby. Okay, these are the histocytes. Intracellular edema between the epidermal cells. You can see it over here. Okay, spongiosis. This is like how it progresses. I don't think you need to know this for the exam. It's over here if you guys want to go look over it. But again, it was added for completion's sake. There's spongiosis dermatitis, okay, which is the same thing, just different name. Water is in the keratinocytes itself and it's outside, and there's microvesicle formation, okay? You can see a tiny vesicle that's being produced over here. Okay, this is here over outline. Okay. Now, allergic contact dermatitis is an allergic reaction. Hapten carrier complex, activation of keratinocytes via engagements of PRRs, inflammasome formation, there's upregulation, production of interleukin-1 and interleukin-18, production of tumor necrosis factor alpha as well. Okay, again, the whole nail polish that I was talking about earlier, this is its pathway. The antigen is taken up. The dendritic Langerhans cells, they take that antigen, they give it to the lymph node, they show it to the naive T cells, effector, and the effector and the memory T cells are like, okay, we'll keep this in mind. If we see it again, we'll attack. Okay. On re-exposure, T cells are primed and they migrate to the infected skin, sorry. Atopic dermatitis, okay, again, same thing. Almost the same thing, but this one is a Th2 immune response. This is a schematic. Just again, keep these in the back of your head. Most likely they're not going to ask you about them unless they really mean. Now, question is acute eczematic dermatitis the same as atopic dermatitis? Okay. Not really, but yeah. Okay. Atopic dermatitis is a chronic condition. Okay. You always have dermatitis. Yeah, also I prefer saying dermatitis. Okay, it's long-term recurring eczema. Okay, it starts in childhood. It's associated with allergy, asthma, and hay fever. The skin is usually dry, itchy, and can't flare up. Acute eczematous dermatitis, it's a phase or a reaction. Okay, active inflamed stage of eczema. Skin is red, swollen, oozing, and crusted. Can happen in atopic dermatitis, contact dermatitis, or other eczema types. Okay, so in a way, think of atopic dermatitis, the big disease. Okay, acute eczematic dermatitis can be a sign, okay, or a symptom, or whatever you want to call it, of atopic dermatitis. Okay, these are more pictures of acute eczematous dermatitis. Okay, atopic dermatitis. This is what it looks like. Starts in childhood. It's early on. It's very like it stays. You grow up with it basically. The treatment, calcineurin, interleukin-4, interleukin-13, and JAK inhibitors. Okay, allergic contact dermatitis. I just mentioned the pathogenesis beforehand. Again, for this specific case is that she wore a pair of sandals, and the material that the sandals were made from, it just didn't go well with her body, so she got like an inflammation on that part specifically. Not inflammation, hypersensitivity response on that part specifically. Photodermatitis, you know the people who are like, oh my God, I'm allergic to the sun? This is what it is. Okay, they develop dermatitis when they see the sun or UV specifically. Oh, for this one, you see it in white people. If like British people a lot, if you see them near the beach, they're just red, lobster red. Drug dermatitis, usually you take drug causes adverse effect. Adverse effect is drug dermatitis. Primary irritant dermatitis. For this picture specifically, it's because fecal matter is not being cleaned. So this could be a sign of neglect when it comes to children. It's usually because, oh, you have something that is bad for you, but it's somehow constantly on your skin. Okay, that's what primary irritant dermatitis is. We reach erythema multiforme. Erythema multiforme. If you get a question about it, they're going to tell you something very, very specific, and it's targetoid lesions. Okay. If you guys get this wrong, there will be consequences. Okay. Erythema multiforme is usually because of infections, drugs, malignant disease, or collagen vascular diseases. Okay. Usually it's drugs. Okay, it's a side effect of drugs. Okay. There's macules, papules, vesicles, and bullae. Target lesion, they have a targetoid lesion. Okay, interface dermatitis. I'll go into that I will show you this is what the slides look like. Okay. Central necrosis has CD8, okay, and perivenular inflammation is CD4. The lymph infiltrates go up, causing a blister. Epithelial cells are killed by skin homing CD8 plus T cells. Salve, okay, it's a reaction. It's a reaction because of something. That something is usually drugs. Okay, this is what it looks like. There's something called Stevens-Johnson syndrome. I don't know if you guys have gone past it or heard about it in some way. Okay, but Stevens-Johnson syndrome, usually it's a very severe reaction because of a drug. Okay, there is a creator on TikTok that got Stevens-Johnson syndrome because of a drug reaction or a bacterial infection. I'm not 100% sure. You can go through her page. I hyperlinked it. It's really interesting. Now, toxic epidermal necrolysis is really dangerous. Okay, Stevens-Johnson is dangerous as well, but toxic epidermal necrolysis is really dangerous. So you have to watch out and make sure and know, like, okay, is the patient fine? Like when you administer a drug that causes toxic epidermal necrolysis, just be like, okay, we're gonna keep you here. We're just gonna make sure you're fine. Fresh infected skin. Okay, there's red keratinocytes in the epidermis. I'm gonna take the wide assumption that it's this. Okay, these are the red keratinocytes. For stale, which is like later or chronic lesions, there's an empty space between the layer and there is CD4 cells. Now, what does this remind you of? The microscopic terms I was talking about? It's vascularization. Okay, so it's tiny vacuoles like right above the basement membrane. Okay, and they have CD4 cells. Targetoid lesions. Okay, cytotoxic CD8 is in the center. The reason I remember it is that the 8 is 2 circles. Okay, and the center is made of a circle. So there are 2 circles. CD4 is in the periphery. Okay, so of 4 and of periphery. Okay, CD4 plus and helper CD4 plus helper T cells and Langerhans cells as well. What's next? Why is this not working? Oh, okay. Erythema multiforme. Highlands are a common area of predilection. This basically means it's like where you most likely are gonna see them. Here in the hands. This is what they look like. Okay, targetoid lesions. Now, Stevens-Johnson syndrome or toxic epidermal necrolysis, vesicular lesions plus skin sloughing. So your skin's genuinely just like peeling off. And you can see it here. You can see it in this patient over here. Their skin, like you do this and it's away. Okay. It's an attack at the dermal epidermal junction. So think basement membrane, basement layer, just right in that area. Okay, causes loss of eyelashes, eyebrows, scarring, hyperpigmentation, and there are some nerve changes associated as well. Now, lichen simplex chronicus, we did not take this, but this was mentioned for you guys. It's hyperkeratosis and parakeratosis, parakeratotic flake. Okay. Acanthosis, there's elongation of the dermal papilla, repetitive trauma or rubbing. The nodular forms is called prurigo nodularis, hypergranulosis, elongation of retiridges. Just constant rubbing in one area, okay? And this is what it happens. This is what it looks like. For a case, I didn't see Robin's questioning this, but I could be wrong. I might have missed something. The etiology and pathogenesis is that there is an HLA association with it. Okay, polyclonal B cell activation. is also involved. There's autoimmune hemolytic anemia, vasculitis, nephritis, and scaly lesion. Like this would be a side effect of those. Okay. This is what it looks like. That's it, really. Okay. Now we get into chronic inflammatory dermatosis. On that note, I drink something. Okay. Psoriasis, you have something. Oh, this is important. Kim Kardashian. Salmon-colored plaque. Okay. What they mean by salmon-colored plaque is not just the inside, it's also the outside. Okay. It's reddish, oranges in a way, and it has like a white layer on top. In Arabic, it's called صدفية. I didn't know this. Okay. It affects the elbows, knees, scalp, lumbosacral areas, intergluteal cleft, and glans penis. It's associated with psoriatic arthritis. Okay, you took it in rheumatology, you take it here. Okay. It's associated also with arthritis, myopathy, enteropathy, spondylitic joint disease, acquired immune deficiency syndrome, pustular psoriasis, pustules. Duh. Okay, more pictures of psoriasis. Okay, as I mentioned before, onycholysis, pitting of the nails, okay, is ايش اسمه? You see it in this disease. Okay, where was it? Oh, this is onycholysis. This is psoriatic arthritis. This is the histo slide. I don't believe this was covered by Dr. Ahlam, but I'm gonna go over it very quickly. There is no stratum granulosum, okay? So a perikeratotic scale is C, okay? So you have nuclei in the keratinocytes that should not have, not keratinocytes, in the dead cells that contain keratin, okay? Typical psoriatic plaques are thinning of an epidermal cell layer, okay? This is what it looks like. Just know it. Poseriform hyperplasia. Keep it in the back of it. This is what they look like, basically. Okay, this is a slide. Okay, this is the histo slide of stuff you would see, and like it just pointed out. This is not part, this was not in your lectures. I just took it from elsewhere, put it just to help you. You see hyperkeratosis. Yes, yes. You see thin suprapapillary epidermal plates. Okay, these over here, it's thin, and you see a clubbed rete ridges. You see also parakeratosis and spongiform pustules of Kojog in spinous or granular layer. Monroe microabscesses in the stratum corneum and dilated blood vessels with surrounding inflammation. Okay. This slide, you go in, you memorize it. Okay. This is really important. You see parakeratosis, we mentioned this before. Elongation of the ridges / pegs. Okay. Where was it? Okay, so these are elongated. Okay, see it in the histo slide over here as well. Okay, these are too long. They should not be this long. Suprapapillary plate thinning, which is Auspitz sign. Auspitz sign, okay, and they most likely will mention Auspitz sign instead of most of the app I'm talking about right now, is that you have skin, you itch. When you itch, you have tiny, tiny like blood drops, okay, that are coming out. Okay, and it's mainly because this is too thin and too fragile. So when you do this, okay, you're taking off the top layer and it's causing a bit of bleeding. Okay, now neutrophil aggregation in the scales itself is called Monroe microabscesses. Okay, see it? Where was it? Here. Okay, this has neutrophils inside. Okay, it's called Monroe. Monroe doesn't have psoriasis. It's just the name reminded me of her. Okay, and in the spongiotic foci of the epidermis, pustules of Kojog. Okay, just know this as is. There's not much to it, صراحة. Keep it in the back of your head. No, keep it in the front of your head. This one you keep it in the front. Okay. More psoriasis, histo slide. Okay. See over here, it's scaly. Let's see. What's next? Okay. This is from your immune lecture. I just added it here because it will help you connect things all together. Now, we said it's a type 4 hypersensitivity response. Th1 and Th17 cells are involved, okay? The damaged keratinocytes release cathelicidins, okay? There is damage associated something proteins, they're being formed, okay? Interferon alpha. Inflammatory response for Th1 and Th17, cytotoxic T cells get activated, okay? CD4 and CD8 are also involved. Important cytokines include interleukin 12, interleukin 17, interleukin 23, and tumor necrosis factor. Please, 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 please remember interleukin 17 and Th17, okay, the T helper cell 17, and know that they are related with psoriasis. Okay, this is what they asked from the immuno lecture, but obviously there are other cytokines, but it's interleukin 17. Interleukin 17. Okay. There is a drug that they are making right now, and it's anti-interleukin 17s to help with psoriasis. There's a growth factor that's responsible for the proliferation of the epidermis. So acanthosis parakeratosis occurs because of the growth factor. Oh, this was a schematic. This is too detailed, but I added it for the sake of completion. This is also a schematic. This is not too detailed, but you don't really need to know this. Like, you don't need to know the full details, but just know, no, it's an inflammation loop, okay? So skin damage, inflammation cycle, skin damage again, inflammation cycle. Treatment, interleukin 17, interleukin 12, interleukin 23, tumor necrosis factor alpha inhibitors, immune targeting, okay? And you can use corticosteroids, vitamin D analogs, vitamin A analogs, STAR. I don't know how TAR is involved, but TAR is involved, and calcineurin inhibitors. Do you need to know the treatment? Not really. But again, added for the sake of completion. Okay. Seborrheic dermatitis. It's a really interesting disease, and I don't know why. It's just like, oh, this could happen. Okay. High density sebaceous glands. Okay, but they're fine. Okay. They're not the ones that are involved in a way. Okay. Macules and papules, reddish, yellowish, and greasy. Scaling and crusting. It's associated with dandruff. Okay, so if you see a patient with these type of rashes and there's a lot of sebaceous glands and there's a lot of dandruff, you think immediately seborrheic dermatitis. Okay, do not confuse this with something else that I'm going to teach you in a bit. Okay, in babies, there's diarrhea and failure to thrive. Okay, and a severe form is seen in HIV patients with low CD4 count. Okay, again, these are information, you just know it as a fun fact of the day. Okay, what's found in the histocytes is that there's follicular lipping. Okay, so it's kind of the follicle itself is blocked. Okay, perikeratosis, neutrophils, and serum is also found. Perivascular infiltrate, lymph, and neutrophils. There's inflammation surrounding the follicle. Pathogenesis is not really understood, but Malassezia furfur is also involved, and Parkinson's disease is also involved in it. Okay. Parkinson's disease, the theory behind it is that there's no dopamine in it. Okay. I just need to take a teeny tiny break. I'll be back, I promise. Okay, I'm back. We have something called, we just covered, what did we just cover? Oh, go back. Okay, we just covered seborrheic dermatitis, again, chronic inflammation. Lichen planus is also a part of chronic inflammation. It's pruritic, purple, planar, papules, and plaques. Okay, the 6 Ps. It resolves in 1 to 2 years. Oral lesions can be present. With lichen planus, just be careful because it can be a precursor lesion for squamous cell carcinoma. Okay, itchy, boiolicious, flat top papules leave zones of post-inflammatory hyperpigmentation. This is the purple stuff. Okay. extremities, wrists, and elbows, and glans penis is involved. There's something called the Cobner's phenomenon, and the Cobner's phenomenon is that if you get a trauma, okay, that that area of the trauma will become purple. Lower epidermal junction is not intact, so it causes a sawtooth appearance. Not this saw either, just here. There's a better picture, I think, later on. Panniculate, necrotic basal cells, collate, civate bodies, hair. Epithelium of hair follicles, lesion planopilaris. Pigmentary incontinence is because of melanophages. Okay. You treat with corticosteroids and calcineurin inhibitors. Okay. I mentioned this should not be here, I believe. I mentioned interface dermatitis before. This is the slide for interface dermatitis. Okay. There's pigmentary incontinence. So you would have purple spots or dark brown spots. Okay. This is mucosal involvement. Where did it go? Okay. See over here, it's a bit darker. Okay. Where is it in the lips? Here's it on the legs. Okay. Finally, okay, we move into something that's a bit more interesting, which is melanocytic lesions and melanoma. Okay. Now, melanocytic lesions and melanoma is basically a disorder of the melanocytes. Okay, it's not usually something to be that worried about, but for melanoma specifically, you really need to be careful. Okay, you need to get it taken out immediately. First thing is a freckle. Okay, if you've seen someone who's very pale or Northern Europeans or Scottish people, they tend to have freckles. It's just macules that appear darker after sun exposure. There's not much to it. This is what a freckle looks like. Okay, lentigo is localized hyperplasia of the melanocytes. So there's like an increase of the melanocytes. Okay. Linear melanocytic hyperplasia produce a hyperpigmented basal layer. Okay, mucous membrane may be involved. Okay, this is what it looks like. It's a precursor lesion for, is it lentigo? No, it's not it's not this, sorry. Okay. This is just like sunspots. If you see like your parents, they would most likely have this. Okay. Melanocytic nevus اللي هو the mole. Okay, we've all seen moles. I have one right here. Can't see it on the camera because it's horrendous quality, but it's just a mole. Okay. Any congenital skin lesion, melanocytic nevus, neoplasm of the melanocytes. Usually, it's not that serious, but if it starts changing color or changing with like the border, or it becomes itchy, or something feels off about it, you need to get it checked out. Okay, these are more examples of melanocytic nevus. Okay, these are child like congenital melanocytic nevus. They're big, thick, and hairy. Okay. Nevus is hamartoma of any tissue. Okay, vascular, there's nevus flammis, sebaceous, nevus sebaceous. Okay, this is what nevus sebaceous is. And vascular, this is what it looks like. Okay. Then keep it at the back of your head. I don't believe it's that important. Okay. Melanocytic nevus, which is the mold. This, congenital nevi. Now, one thing that I feel like if they're gonna be testing you about that they haven't tested about before is a nevi in the leptomeninges. Leptomeninges, you'll take it later in neuro, but it's part of the brain. Okay, the meninges that cover the brain. Okay, it's very difficult to treat. It's very difficult to diagnose because you wouldn't. It's not the first thing that you think of. Okay, it can cause seizures and neurological deficits. Okay, and you're like, okay, this patient, there's something wrong, but we don't know what it is. Okay? Axial, as in it's in the midline of the neck. Okay, this is what it looks like on CT. Here. Okay, next. Okay, for management, you excise the lesion. Yeah, not the lesion. You excise the area, especially if it's cosmetic. For larger lesions, like this patient over here, you do laser. You also do something called a skin flap surgery, where you put a balloon underneath an area, okay, and you just wait for the skin to stretch out, so that you take it, okay, and you fix it up, and the patient looks fine. Okay, this is an evolution. This is this basically. It's just a balloon so that the skin expands. Okay. And they don't start with a big thing immediately. They start small and then they increase. The risk of melanoma in these in melanocytic nevus is about 7%. Piece of information you should know. Acquired melanocytic nevi. This is the most common one. It's not a birthmark. Sorry, it's just a mole. It's there. Okay, with the progressive age, there will be fibrosis, so maturation of the mole itself. So, like for example, this patient, maybe when she was younger, her mole wasn't as defined. Okay, it would have been like a tiny small one. It may lose color over time. You can see over here, like there's fibrosis. Okay, there's some sort of fibrosis and it's losing color. It's not as dark brown as it should be or usually is. Dermal melanocytis, blue-gray patches, lumbosacral region. This is called also Mongolian spots, by the way. It's Asians mainly, okay, but it isn't specific, and it resolves with time. I don't know if you guys have picked up a fresh baby and you've seen this. I saw this on a baby. It was here, okay, and it was just like a blueberry spot. Again, recall. Nevus of the otta is blue-gray to blue-brown nevus, and it's unilateral. Okay, this is the nevus. Okay, involve V1 and V2. These are branches of the trigeminal, and it's most common with Asian and Black people. It doesn't go away. Deep ocular involvement, i.e., it's very involved in the eye. There's iris memulation. This is what it looks like. Okay, the iris itself has like tiny peaks. Oh, and a fun fact, the reason it's called iris memulation is because apparently it looks like nipples. I don't know where and how we came to that conclusion, but it's there. Okay, glaucoma or uveal melanoma. Okay, this is not included, but I found this diagram helpful. You would have a melanoma of the iris or the ciliary body or the coracoid. Okay. Next. Okay. Now, there are two types mainly. A junctional nevus. Okay. Compound type, junctional nevus, they're limited to the epidermis. The compound type, they involve the dermis as well. Okay, so here you see this is the nevus. Okay, it doesn't go below the basement membrane. You see the yellow line? This is the basement membrane. It's not going down. Versus, why is this not working? Okay, the compound type, it goes up and down. Okay, you see like clusters of melanocytes. Okay, that's what a compound nevus is. Again, just know the pictures. Most of this is recalled. They're not going to tell you, oh, what do you see specifically over here? You guys are not histopathologists. Neither am I. This is recall. This is pure recall. I don't know how else to feed it to you, but this is pure recall. You have congenital nevus. They're bigger and more dangerous. You need to watch out, okay? Because it can become a melanoma, okay? There's a blue nevus. It's in the name. It's blue. A dysplastic nevus, okay? The central part is rounded. The peripheral is irregular. Okay, and this is the ABCDE of staging of melanoma. Okay, well, not staging, figuring out if something is a melanoma or not. A halo nevus, there's a halo. Okay, and the reason there's a halo is because there's lymphocytes around that area. Seborrheic keratosis, I'll go into that in a bit. Okay, it's not seborrheic dermatitis. Seborrheic dermatitis, sebaceous glands, dandruff, Malthusia furfur, Parkinson's. That's a separate entity by itself. Seborrheic keratosis is a separate entity by itself. Melanomas, it's a ugly looking mole. It's a hideous looking mole. Okay, and intradermal nevus below the dermis, I believe. Okay, this is the ABCDE I was talking about. Again, this was not in your lectures, but I really liked it. Pulled it from Google. Asymmetry. If they're asymmetrical, you need to watch out. If the border isn't even, you need to watch out. Okay. If the color is like different or it changes in color, you also need to watch out. If the diameter is smaller than 1/4 inch or 6 millimeters, I think in your lecture it was 5 millimeters, I think. Okay. Um, if it's larger than that, you need to watch out. Okay. And evolution. Okay. Evolution and enlargement. If you have a specific mole that increases in size, that's why they tell you, the dermatologists are all about like, oh, just watch out for your moles, make sure they're not growing. Evolution is very is in that category. What the dermatologist is okay. What the dermatologist is warning you about is because of evolution and enlargement. Okay, so is it evolving in the sense of are more spots showing up nearby? Okay. Enlargement is the spot itself, is the mole itself increasing in size. The small one is 1.5 centimeters. The small one is 1.5 centimeters. The medium is 1.5 to 20 centimeters. The large one is 20 centimeters. Giant is cover a large part of a region. Okay. This slide is important. CDKN2A is important, guys. Okay, for dysplastic nevus. You see dysplastic nevus in the question? The first thing you go to, CDKN2A mutation. Okay, that's the main thing that you need to watch out for. It got asked a lot. Okay, in the past, in Robbins, everything. It's always asked about. BRAF, on the other hand, mentioned this one. BRAF mutation is mainly in melanoma, but for dysplastic nevus, okay, it's always CDKN2A. Okay, don't pick anything else. It's that one. Right. Where was I? Different melanomas, A, B, C, D. A. Okay. Is it asymmetrical? No, it's not. Are the borders regular? No, it's not. Is the color like uniform or is it one color? No, it's not. Is the diameter less or bigger than 5 millimeters or 6 millimeters? I don't know. I can't measure, but I'm gonna assume no, it is. Okay. Is it evolving? You can see evolvement, and it's here. Okay. This is more melanoma, more melanoma, melanoma, melanoma. Okay. Four major types of melanoma. Okay, you have the superficial spreading, which is the most frequent. Okay, you have the nodular as in nodules. Okay, 15% lentigo malignant melanoma, 5% acral lentiginous melanoma is 5 to 10. So the palms, the soles of the and the subingual. I don't know what that is. I don't know. Mom. Acral lentiginous melanoma is the most common skin cancer in darker skin tones. Okay, and I don't know if you guys watched House, but there was an episode, and it was a black patient, and he had like a paraneoplastic syndrome. He had paraneoplastic syndrome, and the reason all him and his doctors are trying to figure it out. They're like, okay, what is this? Eventually, House um, looked at the palms, okay, the palms and the soles of his feet, and he found it in his feet, and it was a melanoma, okay, acral lentiginous melanoma that spread, okay, and metastasized and caused a paraneoplastic syndrome. And the treatment for it, you just excise the area, treat chemotherapy, and you should be fine. I linked the House episode about this. Just stuff to help you guys link what I'm talking about instead of me yapping for like 2, 3 hours straight. Where was that? Large, thick, and hairy is what it looks like. Okay. The melanocytic nevus, mole pathogenesis. It's an acquired mutation in the RAF serine thyrine kinase. Yep. Okay. There was a bit of discourse when I was looking through your lectures about which mutation is what, but it's usually CDKN2A for dysplastic nevus, and for melanoma it was BRAF. Okay, this was in Dr. Ibrahim's slide. This was in Dr. Ahlam's slide. Just know BRAF, CDK4 and CDK16. Yeah, that's all. Okay, this is the involvement of a melanocytic nevus. This is dysplastic nevi. Dysplastic nevi syndrome, kind of in a way, is a precursor to melanoma, but not usually. So people with a lot of moles, they need to watch out and know, like, hey, just be careful. Okay, 50% 50% of the patients who are over 16 have it. The P16 has stopped, so there is a proliferation of the melanocytes. It's more than 5 millimeters, flat macules, slightly raised sacs, pebbly surface, or target-like lesions. This is not a halo nevus. Please watch out. Okay, halo nevus, there's a very clear white ring beside it. You can see fibrosis in the dermopapillary layer. Okay, where is it? Fibrosis specifically here. Okay. Lymphocytic infiltrate, melanin pigment incontinence. Yeah. Okay. Dysplastic nevus, another name for it, is atypical melanocytic nevus. It's an acquired lesion, as in acquired. What they mean by acquired isn't like something causes it. It's just that it appears later. It doesn't. You're not born with it, and it doesn't like it appears in childhood. Okay. It's larger and more variegated in color, asymmetric outline, irregular borders. It's a high risk of becoming a melanoma. It isn't a melanoma yet, but it might become. Okay. This is very common in white people. Okay, so make sure you wear your SPF. Make sure you're fully covered up, especially if you're going to be exposed to the sun for very, very, very long periods of time. And don't tan. Don't overdo it with tanning. Edward Cullen from Twilight is very susceptible of dysplastic nevus and melanoma. You have something called a dysplastic nevus syndrome, and it's basically a bunch of dysplastic nevus scattered all over the body. It's an autosomal disease. Okay, the mutation is CDKN2A mutation, and there's 100% of developing malignant melanoma if two people in the family have melanoma. Okay, like bloodline relatives, if they have it, they most likely will develop a malignant melanoma. The management for this disease is just to excise them, just stick it out, keep them under close observation, and they'll be fine. Okay, dysplastic nevi, this is what it looks like under the histopathology slide. It's really a messy cell architecture. Nevus cell nests can be enlarged and confused with other nests. So you have a nest, and then you have another nest, and then they become together. Okay, just like this picture over here. Nevus cell, they replace the basement layer, which causes lentiginous hyperplasia, nuclear enlargement, irregular hypochromasia, lymphocytic infiltrates, melanin incontinence, melanophages. Fibrosis is also present. Autosomal dominant disease, CDK and N2A, again, really important, on 9p21 and CDK4 on 12q14. Do you need to know the chromosome location? I highly, highly doubt so. We're going to talk about melanoma. Okay, sorry, guys, I thought we were recording. Go back. We're going to talk about melanoma. Okay. Melanoma is basically a melanocyte that went out of control. Okay. Melanocyte junctional nevus, compound nevus, changing in contour as cells aren't round anymore. Basically, dysplastic nevus has started. These are this okay, this is what's considered a melanoma. Okay, when it starts metastasizing and going further from where it should be. Okay, if you take out the mole early, you're fine. Okay, more than 10 millimeters in diameter when diagnosing. That's when like you're like, okay, this is definitely a melanoma. Oh, something called Breslow's thickness. I will explain it in a bit, but basically Breslow's thickness is how much of the melanoma has gone deep, deep down, or how much of the melanocyte has gone deep, deep down. That's what Breslow's thickness is. Melanomas, they show different colors: black, brown, red, dark, blue, and gray. Borders are irregular, notched, and not smooth. It can be painful or itchy. Okay. De novo, 70% of malignant transformation of melanocytes at the dermal epidermal junction. Okay, so this is a new mutation. Precursors, they arise, 25% of them arise from pre-existing melanocytic nevi. Darker people, as mentioned before, it's called acral lentiginous melanoma, is the most common, found on the feet and nails. Bob Marley died because of acral lentiginous melanoma. Fun fact of the day. Okay, they're confined to the epidermis above the basement membrane, and there is a variation of color as well. Okay, this is called superficial spreading malignant melanoma. Okay, so it's not going down, it's going up. Like it's kind of like when you spill water, it doesn't really go down, it just spreads. Okay, it's the most common slow growth into intraepidermal or radial growth, vertical growth with metastasis, de novo or precursive lesion. Do you need to know this? I don't think so. But again, keep it in the back of your head. Nodular malignant melanoma. This one, you need to know it in the sense of, okay, are you able to identify that this is nodular malignant melanoma? Uniformly elevated and present with exophytic dome, shaped / polypoid lesions, vertical growth phase, as in it's going down. Okay. Also named vertical growth malignant melanoma. Okay, and it has a poor prognosis. Why? Because it's going down. If it's going down, there are blood vessels. Okay, and through those blood vessels, the cancer cells can metastasize, or the melanoma can metastasize. Next, acral lentiginous melanoma, dark-skinned individual, soles, palms, fingernails, and tail. Hutchinson signs is involvement of the nail fold. The band expands more than 3 mm wide. This is Hutchinson size. Okay, so it's not just the nail, it's the area next to the nail as well. One dark nail is very concerning versus if you have a few that are dark, it's not as concerning because usually it's seen as like, okay, maybe it's not melanoma, maybe it could be an adverse effect of chemotherapy or other agents, for example. Okay. Lentigo maligna melanoma, which is melanoma in situ. Okay. No, pause. Lentigo maligna melanoma. Okay. It's found in older people, face, hands, and it starts with lentigo maligna, okay, which is melanoma in situ. Sorry, guys, I confused you. I'm really sorry. Melanoma in situ is that the 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 melanoma has metastasized, however, it's still confined to the epidermis. Okay, it hasn't gone past the basal membrane. Intraepidermal neoplasm. This is mucosal melanoma. It's very bad, very difficult to diagnose, especially if it's like in a hidden place, so genitals, for example, and you can't find the primary source. These are questions. I added them just for the sake of completion. Okay, dysplastic nevus syndrome, this is really important. The risk of melanoma from precursor melanocytic nevus is 25. Yeah, that's all. Okay, this is the like not pathogenesis, but what actually happens. I highly doubt they're gonna ask you it, but you can go over it on your own time. It's not really that important. Okay. This is like kind of a summary without the picture. So radial growth is horizontal spread. There's no metastasis. Vertical growth, it's going down. You would have nodular and it does metastasize. If it's ulcerated, that's a bad prognosis. Okay. The radial growth phase, there's a lentigo maligna. Okay. It's usually seen in older men and it's just a lesion. Okay. It's just there. Superficial spreading is the most common type, mainly because of sun-exposed skin. Acral/mucosal lentigo is not related to sun exposure. Melanocytic tumors of uncertain malignant potential. It was mentioned in your slides. I don't think it was important. I just added it for the sake of completion. Radial growth melanoma is what it looks like. It's spreading. Okay, it's like pancake batter when you put it on a pan and just okay, doesn't go down. Lentiginous growth and hyperchromatic nuclei. This is what it look like. Okay. Um, this tells you the whether the melanoma is fine, like it will be okay, or whether it won't be okay. The tumor depth, which is Breslow thickness, okay, if it's less than 1.7 millimeter, you're fine. It's not gonna metastasize big. If we excise it, you're not gonna be affected. Okay. Number of mitosis. This is basic cancer 101. Little mitosis, better outcome. A lot of mitosis, bad outcome. Tumor regression. There shouldn't be tumor regression. Okay. If you see a melanoma, it should stay the same. But if it's getting smaller, you need to watch out. Okay. Maybe because it could have hopped into another place and there's a host immune response. Low presence and number of tumor infiltrating lymphocytes. Females tend to have better prognosis. Location. If the location isn't on the skin or sun-exposed areas, you really need to watch out because that tends to be like, mutation sort of. There's a genetic mutation involved rather than chronic sun exposure. Okay. Again, this is why the dermatologists tell you, make sure you cover up when you go outside. Breathless thickness, this is what breathless thickness that I was talking about earlier. This is the basement membrane / the basal layer / BM, whatever you want to call it. Level 1, it doesn't cross. Level 2, it does cross, but it doesn't reach to the reticular dermis or the subcutaneous tissue. Okay. Level 3, it's much closer to the reticular dermis, but it's not really. Level 4 is when it has reached. Level 5 is when it reached the subcutaneous tissue. Please watch out over your moles. Make sure you look at them frequently. Okay. Benign, pre-malignant, and epithelial lesions. Benign epithelial lesions, they're very common. So like skin tags, for example, is a benign epithelial lesion. Stem cells residing in the epidermis and hair follicles. Seborrheic keratosis. Okay. Seborrheic keratosis is what I mentioned before. The whole gist of this is that it's a stuck-on appearance of a. What was I saying? Okay. It's a stuck-on appearance of a lesion. And this is what it looks like. Okay. You just need to know, it has a stuck-on appearance, round, flat coin, like waxy placules, and can be velvety to the touch. If people of color do get this, it's called dermatosis papulosa nigra. And there's verruca plana as well. Okay. They're not going to ask you more details about this. They're just going to ask you, okay, this patient has a lesion that has a stuck-on appearance. What is it? Seborrheic keratosis. Exophytic, sharply demarcated from the epidermis and composed of sheets of small cells that resemble basal cells. Basket weave keratin. So if they tell you, stuck-on lesion, and they were like, we took a slide and it has basket weave keratin, this is what they mean. Okay. Sebaceous gland isn't involved. The melanin pigmentation varies. Hyperkeratosis, horn cysts, keratin, invasion of keratin cysts, FGFR3 gene, rash. Bleh. Okay, just know the FGFR3 gene is involved. Okay, there's hyperkeratosis. It's thick. Its texture looks weird. Okay, now this is important clinically, so I don't think for the exam. Lesser Tract sign is lesser Tract sign is when you have a lot of these lesions, specifically on the back. Okay, all of a sudden you have them, and it's an indicator of an adenocarcinoma in the GI system. Seborrheic keratosis, to treat it, you do cryotherapy, electrocautery, cartridge. Is it important to know this? I don't think so. But again, we live in Al Faisal, so did I miss anything? No. Okay. Oh, this is what the histo slide looks like. Keep it in the back of your head. Highly doubt they're gonna ask you. Dermatofibroma. Okay. Dermal tumor of fibrohistocytes, button-like nodule. Okay. Dimple sign is basically you take it, you pinch it, and instead of it going up, like how usually skin does, it goes down. Okay. It's usually found in females in the lower legs. It's a connective tissue disease, immune suppression. You can find it in immunosuppressed people. HIV, for example. Multiple lesions can be seen in lupus patients. It's hard, pimply, resistant lesions. Treatment isn't really needed. It's benign. It's not really that important. Pyogenic granuloma. This one is a nice one. From the name, you would think, it's involved in bacteria of some sort. It really isn't, okay? It's just a growth with a vessel, and it's a recall thing. So you see it, you say, oh, this is pyogenic granuloma. Now, when you see it, you need to excise it and make sure that the feeder vessel, okay, or the main artery that's supplying it, is cut off. Otherwise, it would keep going. It would keep growing. It's found in the hands, feet, and lips. Yeah, that's it. Epidermoid cyst, closed sac with membrane contained fluid or semicelluloid material, cyst with keratin broken down by stress and lined by a stratified squamous epithelium. To treat it, the epidermolysis, aka pimple popping. I don't know if you guys watched the pimple popping video. There was a doctor, Dr. Sarah, I think, and some of the cases she gets, they're like this big. Okay, just a cyst. I don't know what else to say, Salaha. Acanthosis nigricans. This one is somewhat important. Thickened hyperpigmented skin with a velvet-like texture. It's seen in axillae skin folds of the neck, groin, and anogenital region. The benign type is seen in children and it's associated with obesity and diabetes. The malignant type, middle-aged and older, and associated with a GI adenocarcinoma. So we've had two things, okay? The first one was a lesser tract sign, which was dysplastic nevus syndrome, not dysplastic nevus syndrome, sorry, seborrheic keratosis, and just a bunch of them on the back. Okay, that's GI adenocarcinoma. Acanthosis nigricans is the same thing. Epidermis and underlying enlarged dermapapillae form numerous repeating peaks and valleys. Hyperplasia can be seen, hyperkeratosis. Cells aren't basaloid as seborrheic keratosis, paraneoplastic phenomenon. You need to watch out when someone has acanthosis nigricans because paraneoplastic phenomenon can occur in the sense of like acanthosis nigricans can be an indication of something else. Okay, as we said here, a GI adenocarcinoma. Okay, this pre-malignant epidermal tumors. Okay, it's not malignant yet. Actinic keratosis, precursor lesion that gives rise to squamous cell carcinoma. This is where I got confused with the lentigo. Okay, I thought lentigo would give squamous cell carcinoma. No, that one is fine. It's just hyperplasia of the melanocytes. You're good. Actinic keratosis, okay, it's mainly due to overexposed skin, okay, and you get something called sunspots. Lentigo looks like sunspots. That's why I said, oh, sunspots. Okay. You need to watch out when it comes to actinic keratosis because it can give rise to squamous cell carcinoma. Okay. Usually do, as I said, sun damaged skin, ionizing radiation, industrial hydrocarbons, and arsenicals. It's less than 1 centimeter in diameter, tan, brown, red, or skin colored. So this is red, this is brown, skin colored, and both of them here. Okay. It's rough, it has a rough texture, and this is like one of the points they're gonna put in the clinical scenario. They're gonna be like, oh, a farmer who's been working all of his life in the fields with no sun protection has a spot on his face that is rough to the feel or something. Okay. You think actinic keratosis. Okay. Cutaneous horn can also be present. The lips are called actinic cheilitis. I will show you a picture of what actinic cheilitis looks like. There's a TP53 mutation due to sun exposure. Okay. Actinic keratosis, dermis. In the dermis, there's inflammation and pigment incontinence. That's why like it's the spots tend to be of different colors. Epidermis, there's acanthosis, plus the keratin layers are disturbed. Okay. This. Can you see inflammatory cells on these slides? Why? Me personally, I can't, but if you can, good on you. Okay. Pigment incontinence. Okay. Acanthosis and the keratin layers are disturbed. These are more pictures of it. Again, most of these are recall, these pictures specifically. It has a stuck-on appearance, but 9 times out of 10, when they say stuck on, it's seborrheic keratosis. Okay. Dysplasia of keratinocytes, the gray part, okay, gray, where is the gray? Okay, so like the gray part is usually due to damaged dermis. This one is actinic cheilitis. Finally, we get into something that's more mind stimulating. Squamous cell carcinoma, which is SCC. Okay, it's the second most common tumor. Sun-exposed sites in older people. Males are more, what is it called? Males are more likely to develop it compared to females. The basement layer membrane is not involved, so if it's not involved, it's called in situ carcinoma. More advanced means invasive tumors are nodulars. It can ulcerate. Invasive CCC from polygonal cells with keratin pearls to neoplasm. Associated with geographic necrosis due to highly anaplastic cells. There is no metastasis in CCC. Melanoma there is. Okay. Poorly differentiated, there is moderately differentiated and well differentiated. Well differentiated, you see keratin pearls. The others, you moderated, you might. Poorly differentiated, you don't see. Desmosomes are still present. Okay. Squamous cell carcinoma, as we said, due to sun damage, UV light. Okay, and human papilloma virus 5 and 8. Okay, it's a loss of function mutations in the Notch receptor, TPV3 mutations. The P53 is Kharban, there's no apoptosis. Added for completion, HPV 5 and 8 is important. Okay, should just keep that in mind. And maybe TP53. On that note, go get vaccinated. They're giving out the HPV vaccine for free. Okay, squamous cell carcinoma, this is what it looks like. Here you can see the keratin pearl. This is where you can see the keratin pearls. The cell architecture is just weird, okay? Features of neoplasia, loss of architecture, cytology, variable degrees of differentiation, nuclear crowding, abnormal keratization. Keratin pearls are also present. There's atypia across all the epidermal layers. These are different presentations, okay, of squamous cell carcinoma, but usually it's red, okay? It's kind of superficial in a way. This is what it looks like. Leukoplakia is a squamous cell carcinoma, so just keep that in mind. Immune suppression. Oh, leukoplakia is very common in immune suppressed people. Squamous cell carcinoma Again, more of it. Okay, full thickness atypia, atypical keratinocytes invading the dermis. Yeah, that's it. Highly differentiated, firm and hard on palpation for invasive. Okay, squamous cell carcinoma. For poorly differentiated, it's soft and granulomatosis, cauliflower-like. This is an ulcerated squamous cell carcinoma, poorly differentiated. This is the skull of a patient, okay, and it's almost gone. Keratoacanthoma, well-differentiated squamous cell carcinoma, regresses spontaneously, cup-shaped tumor with a central depression. And this is not really important, but it's there. Lobules of squamous cells with glassy cytoplasm undergo keratinization without intervening granule layer, brisk lymphocytic and eosinophilic cells. Okay, this is what it looks like. It's a volcano. Keratin is in the center with the squamous epithelium. It forms a cup. Okay, the basement membrane isn't intact, so make sure you take it out. Okay, these are other pictures. Basal cell carcinoma. This one is important. Okay, most common invasive cancer, sun-exposed sites in white people. This one rarely metastasizes, unlike melanoma. As I mentioned before, immunosuppression, DNA repair defects, xeroderma pigmentosum. This is mole 1, I believe, content, which has to do with the thymidine and thymidine bases and the fact that when UV light hits them, they form a double bond with each other and it causes skin problems. Okay, rodent ulcers can occur. There is multifocal growth. Origin comes from the epidermis. Nodular lesions grow downward into the dermis. The reason it's shiny is because of mucin. Okay, so if they tell you, oh, this lesion is shiny and it has anglactasia, which is like blood vessels on it, you think basal cell carcinoma immediately. Round hypochromatic cells, ulceration of the epidermal surface with downward vertical growth, cords and islands of basophilic cells with hypochromatic nuclei appear shiny because of mucinous. Again, already mentioned this. Basal cell carcinoma, this was stressed upon in your lectures, I believe. However, I don't think it would come, but it was added. Okay, so what happens is that the sonic hedgehog gene, no, pause. There's a PTCH and a SMO, okay? These are proteins. They should be stuck together, okay? What usually happens is that the sonic hedgehog gene comes, okay, binds to the PTCH1, okay, and then they separate. When they separate, the SMO, okay, puts the cell into a transcription factor, and there's activation of gene expression. With a mutated PTCH, they can't connect, okay? Because what the PTCH does is that it's telling the SMO, it's like, pause. I don't need you to work right now, okay? But if it's mutated, it can't work properly, so it causes extra proliferation. Okay, this is the cell mechanism disorder, I guess. Okay, P53 mutations also involved, and this supports the multi-hit hypothesis in the sense of like there are multiple factors involved for the to cause basal cell carcinoma. Nodular BCC is this is what it looks like. You need a flap to close the hole when you remove the BCC. The rodent ulcer, it's really ugly, it's invasive, you need to watch out. Sclerosing BCC is just kind of more superficial. And the way I remember this, it reminds me of what if you put like the scar tissue stuff that you get from Amazon for Halloween. That's what it reminds me of. Okay, so yeah. Superficial spreading BCC. Low-key, it does look like a squamous cell carcinoma, but just memorize that these two images are superficial spreading BCC. Pigmented BCC, this can look like a melanoma, so we need to biopsy it for proper diagnosis. Pigmented lesions are common in the region. When doing flaps, we need to take account multiple stuff, especially patients with comorbidities, okay? Gorlin syndrome, BC Nevis syndrome, okay, it's just a bunch of basal cell carcinomas all over the body. Okay, this is what a patient with xeroderma pigmentosum. That's why for these people, you tell them, don't see UV light ever. BCC, more pictures. There's the superficial type, there's a nodular type. This is the histo slides for it. Okay. Again, superficial nodular, micronodular. I think those are the two images. Forgot to remove it from here. Sandy. These are the images. I don't think you're going to be asked about them, okay? Because otherwise I would have mentioned it. But again, keep it at the back of your head. You're not going to be asked about, oh, point out what's actually wrong. It's just going to be tell you, oh, diagnose it. And maybe, if they're being mean, they will ask you for like the pathogenesis of the disease, for example. MOH surgery, okay? It's basically you take the flap, you cut it until you're like, okay, this part doesn't have the BCC or the melanoma or whatever, and then that last part you put it back. I think that's how it is. Okay, and it's just for you guys to mention, for you guys to know. Fitzpatrick scale. Fitzpatrick scale is basically putting people into categories based on their skin tone. You have type 1, which is the very, very fair people, very pale. They get burnt easily. Think albino skin, okay? Type 2 is like Sweden, Norway, Finland areas. Type 3 is very common. Most like the Mediterranean line has it, I believe. Type 4, like the Saudi region. Okay, so ever so slightly darker, slash tan, like they're considered more tan. Type 5 is dark brown. Type 6 is black. Now, type 1, type 2, these people have a very high chance of developing a skin cancer of some sort. Type 4, 5, and 6, not really. Okay. This is just a table to differentiate them. Okay. But wallah, this is the histology. If you guys want to learn about the histology, I don't think it's important. Okay, just know the histo slides that they belong to this or that. Okay, finally, blistering disorders and panniculitis. You basically have a lot, and I mean a lot of blisters. Okay, this is just to tell you, like what's wrong, the main mechanism. There's something called the desmosome, and a desmosome joins one cell to the other cell. A hemidesmosome joins the basal lamina to the cell at the top. Okay. Here, where's the picture? Okay. Here you have the different blistering disorders. Okay, the subcorneal, the corneum layer is not attached to the granulosome layer anymore. Suprabasal, the basal layer is still intact, okay, but the layer above it isn't, okay, which is, I believe, is the spinosum. The spinosum isn't. The subepidermal, the whole epidermis is gone. Basement layer. This one, problem between the corneum, granulosum, and the lucidum. Basal layer, it's fine. It's just the desmosomes, the nails that are connecting the cells to each other isn't fine. The subepidermal, the hemi, okay, so like half of a desmosome isn't fine. Okay, there are a few proteins that you need to know, mainly desmoglein 1 and 3. Desmoglein 1 is from the top to the bottom. Desmoglein, this should be 3, I'm sorry. Desmoglein 3 is from the bottom to halfway up, okay? BPAG1 and PBAG2. Okay, these get attacked because of the immune system. Type 2 hypersensitivity response. This is what it looks like. Okay, this I believe is suprabasal. Yeah, suprabasal, because you can still, to some extent, see the the basement membrane. Okay, this is more of the histology. This belongs to a specific disease. I'll go over it. You can see the slide in the corner. Okay. There's a characteristic tombstoning and acantholysis of the histology slide. These are just introduction. We'll get into actual diseases right now. Okay. Pemphigus vulgaris is the most dangerous one and the most common, I believe, as well. It's autoantibodies that develop against the desmoglein 3. Okay, so we said desmoglein 3 is from the bottom to halfway up. The autoantibodies, they attack it, so it kind of unzips or undoes the tightness between the cells. Unzip the adhesive interactions of desmosomes. This was from your immuno lecture. Okay, now we said autoantibodies. It's usually IgG. Okay, IgG autoantibodies against desmogleins. Characteristic fishnet-like appearance of IgG deposits. If it's all levels of the Pemphigus vulgaris is DSG1, desmoglein 1 and 3. Okay, if it's just if it's Pemphigus fallacious, it's fallacious. Anyways, that one. It's desmoglein 1. Okay. Vulgaris, you can see the fishnet appearance, and it's throughout the whole thing, because we said 1 is throughout the whole thing. Okay, and 3. The other one, I'm gonna stop saying its name. The other one, okay, is mainly towards the bottom, and there is a better picture. Okay, this is what it looks like. Suprabasal, okay, acantholytic blister. Oral ulcer, skin manifestation. The basement membrane is intact. Acantholytic cells, tombstones. Tombstone appearance is the most important. Okay, tombstone in the histology slide itself. Here, let me show you. The histology slide itself. Okay, you can see tombstones. This is how you diagnose Pemphigus vulgaris. Okay, the diagnosis is history and examination and a positive Nikolowski sign. A Nikolowski sign is that you take the skin, you do this, okay, the skin peels off with you. Okay? You do ELISA, you do histology, direct immunofluorescence, chicken wire fishnet appearance, okay, IgG and C3 around the keratinocytes. Okay. Abso-Hansen sign. Abso-Hansen sign, I think if I remember correctly, okay, is that when you touch a blister, it spreads, okay? So it's kind of like, I don't know, I'm trying to think of a way to explain it, but let's just say you have a piece of Play-Doh and there's a sheet of plastic on top, okay? If I were to press that sheet of plastic, that Play-Doh will move, okay? It will spread, okay? And the reason is because of the defective DSG1 and DSG3. Pemphigus fallacious, superficial epidermis problem, stratum granulosum. Its diagnosis is very similar to PV, but this one is the most common. And if you really want to differentiate between the two, immunofluorescence. Okay, where was I? Just to compare, again, this is a schematic I got from the internet. The spinous layer, upper and mid epidermis, eczematic blisters, frictional blisters, or viral. Spinous layer, suprabasal, Pemphigus vulgaris. Basal cell area, epidermolysis, Bullous simplex. Lamina lucida, Bullous pemphigoid, IgG, dermatitis, or hepatitis. I'll go over these. This was a summary. I just included everything together. Yeah. Okay. Paraneoplastic pemphigus. Pathogenesis is IgG targeting desmosomal and non-desmosomal proteins. Okay. IgG, go crazy. It attack everything. Okay. It's seen in non-Hodgkin's lymphoma and chronic lymphocytic leukemia. Severe mucosal involvement. Diagnosis is histology and Ig/complement deposition. Will you be asked about this? I don't think so. Okay. Bullous pemphigoid, okay, is when you see the immunofluorescence, okay, is on the basement membrane. This one is important, okay? It's seen in the elderly. There's tense bullae with clear fluid, subepidermal, so therefore there's no rupture, okay? Oral lesions may be present. Fluid is coming from the dermal/epidermal junction. No acantholytic blisters, unlike pemphigus, what was it called? Vulgaris and Bullous. Okay. Subepidermal blister plus linear band deposition of IgG. Okay, it's very likely to be bullous pemphigoid. So we said bullous pemphigoid, linear IgG deposition. Okay, vulgaris and fallacious is IgG and it's fishnet/chicken wire appearance. Okay, most common vulgaris. Okay, the pathogenesis, linear deposition, we said this, autoantibodies against BPAG1 and BPAG2, which is collagen type 18. This protein is the one that causes the blisters, okay? There's severe pruritus and a negative Nikolsky sign. A negative Nikolsky sign is what I mentioned before. I do this to the skin, it peels, okay? Here, it's not there, okay? It's negative. It doesn't exist. That's how you differentiate between these two. Now, dermatitis herpetiformis. This is IgA, okay, deposition, linear deposition, granular deposition of IgA. And the clinical scenario that they're most likely to get is like, oh, patient with celiac disease or patient who just had like a big thing of pasta or bread and developed these lesions or slash blisters on their arm or forearm, for example. Okay, it can be drug induced. Okay, but there is a gene predisposition which is HLA-DQ2 and HLA-DQ8. Okay. Selective at the tips of the dermal papillae, there's neutrophilic microabscesses. You can see it here. Okay, you can see the neutrophils here. Okay, this is more stuff I wanted to add because I felt bad not including. Critical pemphigoid, which is mucous membrane pemphigoid. It's rare and chronic. It's IgG against BNZ protein. It's a bunch of proteins in the skin. Do you need to know them? Okay. If it's ocular, it's conjunctival scarring and blindness. Oral, gingival erosions. Cutaneous involvement is very, very rare. Then you have non-inflammatory blistering disorders. Epidermolysis bullosa. Okay. Infectious blistering disorders, herpes villus, and impetigo. Okay. Herpes simplex virus 1. Lower left is shingles. Lower middle is Staph aureus, right is insect bite, and friction blisters. They're gonna ask about impetigo, which is Staph aureus. Will they ask about the rest? Oh, they will ask about the shingles, the varicella zoster, sorry, and the maybe herpes simplex virus. Okay, اللي هي بوست سخونة. Okay, for the Arabic speakers, I don't know if you guys get like sores over here. Okay, in Arabic we call it بوست سخونة. Okay, non-inflammatory blistering disorders, epidermolysis bullosa. it's an inherited disorder, so there is mechanical instability. Okay. Uh, the junctional type is lamina lucida alpha 6 beta 4 integrins and laminins 332. Dystrophic types below lamina dense mutation in COL7A1 gene. This is not really that important. Just know it's usually like in babies who are born. Okay, so they would be like, oh, there's a lot of bullae on a newborn. You think epidermolysis bullosa. Okay, vasculitis or panniculitis. With this lecture, the doctor that taught you, I believe, uh, is the same. However, when I went back over the slides, we had more stuff. Okay, but you guys didn't. So focus on the stuff with the star. Okay. Oh, and also vasculitis, panniculitis, you're not taking it in detail, you're just taking the fact that it exists because you're gonna be covering it again in CVP and renal. Vasculitis fibrinoid is a fibrinoid necrosis of the blood vessel. There's a neutrophilic infiltrate, extravasation of RBCs, positive immunofluorescence. Treatment, always steroids. Small vessel, there's IgA, okay, Hemonix, I don't know these names, man. IgA, which is the most common. Urticaria vasculitis is seen in children, secondary vasculitis, drug infections, hematological disorder. With vasculitis, you always check the kidneys, okay? Because if the kidneys are damaged, you will have blood in your urine, you'll have protein in your urine, your filtration rate will go down, which causes toxins to build up in your body. Okay, this is what it looks like. Okay, non-blanchable is the glass test I was talking about. You put a glass, okay, if it goes away, that means it's blanchable. Like the red lesion, if it becomes white, it's called blanchable. If you take it out, it's not blanch. If you pause. Blanchable, red lesion. You take glass, you put glass. Glass, the red lesion go white. That's blanchable. Non-blanchable is that even if you put glass, the red doesn't go away. IgA vasculitis, infection due to strep, upper respiratory tract, appears in children less than 10 years of age, child with flu, purpura, and their joints are swollen. Medium vessel vasculitis, this was asked before, and it's polyarthritis nodosa Kawasaki. Kawasaki disease is a disease seen in children. There's fever, strawberry tongue, conjunctivitis, rash, mucocutaneous changes, and hearing problems. Polyarthritis nodosa, kidneys, testicles, and large organs are involved. There's a network-like pattern on the skin, okay, and livedo racemose. Now, livedo racemose isn't a disease by itself, it's just a symptom or sign that may appear, okay? Mixed small and medium, you have microscopic polyangiitis. No, wait. Eosinophilic granulomatosis with polyangiitis, Churg-Strauss disease, asthma, eosinophilia, and kidneys, P-ANCA positive. Okay. Churg-Strauss, asthma, eosinophil. So think like allergies, seasonal allergies for some reason. That's how I connect it in my head. Microscopic polyangiitis, kidney involvement, P-ANCA positive, there's no granulomas. Granulomatosis with polyangiitis, Wagner's, lungs, upper airways, and kidneys, C-ANCA positive. Chiroglobulinemia, cold sensitive proteins causing peripheral vasculitis. All of this jazz, okay, you guys are going to be taking CVP. I'm just adding it for completion, okay? For Wagner's, the way that Pathoma explained it is that there's a C, draw a C on the patient. So there's nasopharynx involvement, lung and upper airways involvement, kidney involvement. Okay, so if I were to draw a C on a sick person, that's how it would look like. Signs of vasculitis, livedo racemose, subcutaneous nodules, ulcers, more panniculitis, okay? Panniculitis, oh, This should be at the other end. بس المهم pancreatic panniculitis, it's a painful nodule that oozes out melted fat. It's usually seen in alcoholics and it's in the hip area. Okay, tender subcutaneous nodules, Crohn's disease, post-streptococcal infections, birth control pills and pregnancy. Yeah, there's not much to it. This is what it looks like. It's kind of, in a way, bruises, but they aren't like fully formed blue bruises. It's just like oh, I hit my leg by a table, but it's multiple of them. Okay. Panniculitis is a reaction in the subcutaneous adipose tissue, specifically the septa separating the lobules. So here, the lobules, sorry, okay, or the lobules themselves. Okay, you have erythema nodosum and erythema enterotum. Okay, erythema nodosum, infections due to beta hemolytic streptococcal infection. Okay, for a lot of the bacterial infections of the skin, it's usually Streptococcus or Staph aureus. There's no vasculitis, okay? And for nodosum, specifically, it's the anterior lower legs. It's not the posterior, it's the anterior lower legs. There's an N in nodosum, there's an N in anterior. Click one and one together or two and two together. Early lesions show widening of the CT septa because of edema, fibrin exudation, and neutrophil infiltration, lymphocytes, histocytes, multinucleated septal fibrosis, and it's usually a symptom rather than a disease. But I'm just giving it to you here. Okay. Erythema enterotum. Okay, it's in the posterior lower legs, and this one has vasculitis. Okay. If it has no vasculitis and it's in the interior, and it's in the anterior, sorry, then it's erythema nodosum. Okay, this one, on the other hand, is vasculitis is there, and it's in the posterior lower legs. Okay, and there's granulomatosis, inflammation, and zones of caseous necrosis, and necrotizing vasculitis. Okay. Now we're going to talk about acne. Most you guys have probably had we've all had our fair share of acne. Whoever doesn't, I'm jealous of you. But in the sense of like we've seen it, we know a thing or two about it. It's not that big of a deal. This is the pathogenesis. Okay, so you have your hair follicle, you have keratinocytes. You have your hair follicle, okay? You have keratinocytes, they block this area, okay? And then it starts, the more keratinocytes start building up there as well, okay? And it causes pimple, okay? And when there's like a lot of keratinocytes, there's also a lot of inflammation, and the neutrophils would be involved. I included it here. You don't really need to know like the depth detail, but just keep it in the back of your head. Acne, another thing of acne is that there's something called open comedones and closed comedones. If the tunnel is open, it's a white. If the tunnel is open, the keratin inside is getting oxidized by air, and you get a black comedone. Okay, in a way, it's like blackheads. Okay. If the tunnel is closed, it's called a white comedone. For the treatment, you use sterolytic agents, salicylic acid, hyaluronic acid, retinoids. If you spend 10-15 minutes on TikTok, I'm pretty sure you've heard about these from an influencer, or you've seen it in the pharmacy. Okay. Inflammatory acne is because of Propionibacterium acnes. Okay, it's one of the microbiota. It just gets too excited, produces lipase. There's free fatty acids, and it causes inflammations. The skin's like, okay, what is going on? There's moderate inflammation. You give tetracyclines or macrolides. Severe inflammation, nodules, and cystic lesions, and systemic antibiotics. Okay. And in severe acne, you give isotretinoin. It's a cream. You can find it in the pharmacy actually. Uh, or birth control pills. I think I forgot to mention acne in kids, okay, and I'm talking like 9, 8-year-olds or someone who's over the age of 2, um, is you need to watch out for their hormones. You need to do a hormone check for them because acne can be caused by excessive androgens. Older females as well, if they have like acne, you check their hormones. This is more pictures of acne. Okay. Um, Genetics is a factor, hormones is a factor, diet, high glycemic index, i.e., like a lot of sugary food, dairy products, cosmetics can cause acne, drugs, steroids, lithium, phenytoin, EGFR inhibitors, iodides. You're not going to be asked about most of these, it's just good to know. These are the different types of acne. You have acne vulgaris, which is the most common, acne conglobata, pustules, and cystic lesions. Infantile acne is normal up until 2 years old. I mentioned this. Acne excoriae, excess picking, acne fulminans, severe form with nodulistic acne plus fever and bone pain, chloroquine behind the ears, manhandling oils, and greasy materials. I don't know, it's just there. Types. Rosacea. Rosacea is a disease where the skin is just constantly red and it's constantly flushing. Okay? Central phase starts 30 to 60 years old. There's erythema, the blushing. Okay. It's aggravated by sunlight. There's the pathogenesis is like vasodilation, interleukins, and stimulation of androgenic receptors. Give vasoconstrictors or laser. Okay. It has genetic background, microbiome alteration. Do you need to know all of this? Not really. Okay. These are the different types of rosacea. Okay. Again, as I said earlier, dermatology doctors are not looking for you to describe the disease. They're just saying, oh, what's this? Hair types, lanugo is like soft baby hair. Okay. Vellus hair is fine, non-pigmented short hair seen in children. So like peach fuzz. Okay. Terminal hair is the hair that's on your scalp, your eyebrows, your eyelashes. Alopecia. Okay. Alopecia areata, I mentioned before in immunoenophy, regulatory T cells, or they're in a salahiyya with another type of T cells, just to make sure there isn't overactivation of the cytotoxic T cells, I believe. Otherwise, they attack the hair follicle and the hair falls out. This is it. Um, Alopecia totalis is the whole scalp. Alopecia universalis is all of the body. You stimulate new hair growth with minoxidil and decrease shedding via 5-alpha reductase inhibitor, اللي هو finasteride, which I believe is also a drug used in BPH, benign prostatic hyperplasia. Alopecia, there are types to it. If the hair follicle exists, it's non-scarring alopecia. If the hair follicle doesn't exist, there's fibrosis instead, there's scarring. Inflammation that destroyed the hair follicles, lupus, tinea capitis, folliculitis, declavans. Oh, go back. Okay. Females pattern hair loss plus acne hairstome. It's a PCOS what do you call it, Ya Rabbi? A PCOS indicator. So usually for females, we're not getting like thick black hair over here, specifically where in a male, that's where the beard area would be. If some girls do have it, they need to suspect and know, oh, I might have PCOS. Okay. And there's also pattern hair loss, like decrease in hair density. There's also something called postpartum hair loss. It's when uh, it's when basically the mother gives birth and she loses a lot of hair postpartum because the not estrogen, the other one. Okay. These are the pattern of baldness, topical, minoxidil, systemic, finasteride. Again, you know this. Okay. Now, the hair growth cycle is really important. You have an anagen, which is an active growth phase, which is when your hair is actually growing, and it's for 2 to 6 years. You have a catagen, which is a transition phase. Okay. Um, the hair growth stops. Telogen is a resting phase, which is the last variable periods of body site. The average is 3 months. Exogen is when your hair starts shedding. So, um, every once in a while, you would notice, oh, I'm losing a lot of hair. It's most likely because the hair is in the exogen stage. Okay. Telogen effluvium. Okay. Due to diet, the telogen phase is 3 months. Okay. And it's postpartum. Chemotherapy causes baldness. Okay. This was exogen hair shedding phase, physiological hair shed. What's going on? Physiological hair shedding. Lesion is resting phase. Yeah, you guys know this. Ancient. Okay. Viral infections, let's try to speed through it. These are warts. Okay, you know what a warts is. I'm pretty sure you know what a warts is, but it's basically a growth that's caused by HPV, which is a double-stranded, no, not double-stranded, a DNA virus specifically. HPV 6 and 11 are genital warts. 16 and 18 are the oncogenic variants, so you need to watch out. Verruca vulgaris, most common, and it's hidden in the basal layers. Diagnosis of warts based on appearance, location, and location. Dermoscopy, you look at it under a microscope. The dermoscopy is that there's a specific lens that dermatologists use to get a deeper look into it. You see thrombosed capillaries, which are like black dots. Biopsy is rarely needed and shows coilocytes. Okay, freeze it or burn it off. Keratolytics also work. Molluscum contagiosum. Okay, MCV, which is pox virus, direct skin contact or contaminated objects. Virus replicates in the keratinocytes. These are the molluscum bodies. They're enlarged cells with eosinophilic cytoplasmic inclusions, and it resolves on its own. It's fine. Just keep them at home. The diagnosis, it's a four-leaved clover-like rosette. Okay, this is what it looks like. There's something called Patterson's body. They're circled here. You can't really see them. They're not really important. Just know that this disease exists. Okay. Human herpes virus, HCV1, 2, varicella zoster. They would cut the one where it's reactivated. It causes like not shingles. What was it? Okay. I'll look into this. Okay. Latency, direct contact, or respiratory droplets. Okay. HCV1 is normal. Okay. It's the cold sores I was talking about earlier. HCV2, on the other hand, is sexually active patients. Okay. And it causes urinary retention. Okay. The virus enters via mucocutaneous contact, the replication epithelial cells. It gets reactivated by stress, UV exposure, and immunosuppression. The diagnosis, you take it, okay, you do a T-Zank smear, and you see multinucleated giant cells. There's direct fluorescent antibody. The gold standard is PCR, and it shows viral DNA. Serology shows you past exposure, give antivirals, and valacyclovir. Varicella zoster virus is due to HHV. Okay. In children, it's called chicken pox. Okay. Oh yeah, it was shingles. Varicella was shingles. And in adults, if it gets reactivated or they catch it as an adult, then it's really dangerous and you need to watch out. Okay. This is what it looks like. It's chicken pox in kids. This is what it looks like in adults. Do droop Dew drops on a rose petal is the way the doctor explained it. This is what they mean. It's just red and shiny. Okay. Diagnosis, again, Tizank smear, multinucleated cells, direct fluorescent antibody, and gold standard is PCR. Hand-foot-mouth disease is a disease of kids, okay, and it's caused by Coxsackie A16. It's transmitted via droplets, so you put the kids far from each other, okay? It's seen in kids under 10 and it enters the mucosal surfaces and disseminates through bloodstream, leading to vascular eruptions on hands, feet, mouth. Okay, it's in the name. You diagnose based on how the vesicles look like, but PCR is all you always do PCR to confirm its presence. It resolves on its own, give antibiotics, which is like anti-nausea medication and hydration, and they should be fine. Keep them at home. Okay, if a kid is sick, just keep them at home. This one is pityriasis rosacea. Okay, post-viral exanthem with strong association with HHV and 6 and 7 children, adolescents, and young adults. Herald patches is the initial lesion, then Langer lines, so a Christmas tree pattern. This is the Christmas tree pattern that they're talking about. Not Gouty psoriasis since it's post-infection. Doctor didn't really go into depth about this, okay? But again, added for completion. Okay, Gianti-Crosty syndrome. It looks gnarly. It looks weird. Okay, it's a self-limiting dermatosis triggered by viral infections, immune response to viral antigens. Okay, children are under 6 years old after upper respiratory tract infection. Symmetrical erythematous papules on face, buttocks, and elbows. You take a good history, okay? If a kid comes up to you and they're like, oh, the parents are telling you, oh, but the kid had like a viral infection a few days ago, it's most likely this, okay? Especially if they come up with this, like, with this skin lesion, okay? Added because it was included in the lecture, common bacterial infection. The normal microbiota, Cutibacterium, Staphylococcus, and Corynebacterium are found in moist skin folds. Folliculitis is when it's around the hair follicle. Furnicle is hair follicle and deeper. Carbuncle is hair follicle and deeper and another hair follicle involved. Okay, impetigo is really important. Okay, it's usually seen in kids mainly due to Staph aureus, and there is a non-bullous and bullous impetigo due to ETA or exophilative toxin A or B, group 2 Staph aureus. Okay, there's also group A, beta hemolytic streptococcus, which is non-bullous impetigo. If left untreated, both streptococcal glomerulonephritis, Staph aureus specific, no, not Staph aureus, sorry. Strep specifically, if it's left untreated, causes glomerulonephritis, which is the inflammation of the glomerulus. And when that happens, you lose blood and protein from the urine. Okay. The clinical is honeycrust. It's contagious in children. There's DCG1 cleavage, and there's something called staphylococcal scald skin syndrome. I'll talk about it in a second. This was from the derma lectures. I included it just in case. Okay. Bacterial folliculitis is inflammation of the hair follicle because of Staph aureus. Okay. And involves the face wherever you shaved and you didn't use proper shaving techniques. When you razor, make sure your skin is clean and exfoliated. Okay. Let's see. Abscesses, furnicles, and carbuncles. Okay. Anywhere in or on the body is cutaneous, and it's usually inflamed, pus-filled. Furnicles, boils, the hair follicle is involved, and Staph aureus is involved as well. Okay. Again, these ones specifically is just like, oh, point. Is this what what is this? Okay. Blistering distal dactylitis, it's in children 2 to 16 years old, group A, beta hemolytic streptococci or Staph aureus. As I said, either streptococcus or Staph aureus. And by the way, we got a question, not about this case specifically, but I remember in my exam, it was like group A streptococcal, hemolytic streptococcus or something. So just pay attention to the bacteria. I'm pretty sure the micro crash course, if you guys had one, would have covered. Eczema, okay, it's a deep variant of the non-bullous impetigo. Again, group A beta hemolytic streptococci, or a superinfection of streptococcus, and it's usually because of an insect bite. Okay, why is this weird? Staphylococcal scalded skin syndrome, okay, hematogenous dissemination of the exfoliative toxins. I mentioned them before. Okay, the DSG1 is affected. Staph aureus. ETA is chromosomally encoded. ETP is plasmid component. Okay. SS, SSSS, okay, is superficial and it heals quickly. You just make sure they're fine, okay? The kids specifically, toxic epidermal necrolysis, like we talked about it before, that one is deeper and it heals more slowly. If they're gonna ask about this, they're just gonna say, "Oh, and no, he had a staphylococcal infection." Sorry. Okay. Toxic shock syndrome is an acute multisystem disease caused by Staph aureus exotoxin. Recently, strep became involved, and it's more dangerous. Okay, it's like a disseminated bacterial infection, and it's because of a long wear of tampons. Scarlet fever, group A beta hemolytic streptococci, pyrogenic exotoxins, goose maples and pastilla lions. Not really important, added for completion. Cellulitis, Shui important. In immunocompetent adults, it occurs in immunocompetent adults due to group A streptococci or Staph aureus. In children, due to Staph aureus, deep dermis and subcutaneous tissue that manifests as areas of erythema. Four cardinal signs of inflammation, complication due to acute glomerulonephritis, lymphadenitis, and infectious endocarditis. Erysipelas, superficial variant of cellulitis due to group A streptococci, which affects the dermis and lymphatics are involved. This is a superficial variant of cellulitis, okay? Lymphatics are involved. Oh, I mentioned it twice. Staph aureus, pneumococcus, Klebsiella, okay? This one, no scar, okay? Guys, hanat, wallah hanat, okay? Necrocytic fasciitis, it's flesh-eating bacteria. Okay, this is what it looks like. Okay, and you need to differentiate between cellulitis and necrotizing fasciitis. Did the doctor tell me how to do that? No. Okay. Now, finally, we have the fungal infections. We have tinea pedis, which is fungal infection in the feet. Okay. Hot, humid weather, occlusive footwear, and excessive sweating. Interdigital between 4 and 5th toes. You pick it up if you walk around barefoot. I believe it's called athlete's foot. Tinea manum, again, same thing as before. Hyperkeratosis, 50% unilateral, associated with tinea pedis or onychomycosis. Inflammation is minimal. Tinea cruris, inguinal region, groin and thighs. Hot, humid environment, tight clothing, obesity, and topical use of steroids, there are a higher chance. Okay, when you want to diagnose, you take the fungal scraping from the edge or the border. Okay, tinea. Oh, this should be corporis. Tinea corporis is just on the body, kind of lesions everywhere. Zoophilic transmission, scaly plaque, and cause pustules. Tinea fasciae is seen in children, and the facial skin is affected. Most of these, their names are connected. Tinea capitis, it's fungal infection of the hair follicle, okay, or the scalp in general, okay. Kerwin is extensive inflammation that can lead to alopecia if left untreated. Tinea barbae is, again, like shaving. I lost the word. What was it called? God. Oh my God, I lagged. Mainly due to beard, okay, and improper shaving techniques. Onychomycosis, okay, fungal infections of the nail beds, okay. Candida, um, thrush, okay, pseudomembranous candidiasis. This is what it looks like. Just need to know it, okay. Leukoplakia was also seen in squamous cell carcinoma. Candida intertigo, okay. It's usually in the exo. Just know it as a concept. Okay. Question time. Sorry, guys, I went a bit too long and I want to finish this soon. I added an MCQ. You guys read, okay? I explain. Pause. Okay, we read. Okay. Extensive 10-year history of recurrent lesions, extensive surfaces of the elbows and knees, as well as the scalp and lower back. The lesions are well demarcated, thick silvery scales. What are we thinking of? That one. Okay. Nails reveal small pits and areas of oncolysis. Okay. Um, yeah. Okay. This is the questions. Try to answer them. These are the answers. I'm not sure if this is considered as pathogenesis. Okay. But this is where I would clump them up together. Okay. This this is quite important, but not really. I don't know. It's interesting to know. Histological findings اللي هما هيدول. Okay. And the rest is MCQs. These are Robin questions. Because with the issue with the collected is that they're only giving you the main points. They're not giving you the whole clinical scenario. So make sure you go over Robins. Okay. Okay. These are MSI summaries I used when I was doing MSI. I made a dermatology summary. One of my friends, she's a fourth year, Reem Ahmed, she did a dermatopathology summary. Qaida made notes as well. Okay, these are rheumatology summaries. There's Jude Jamjoon's MSI review, so it's a collective of everything. And there's Jude Jamjoon's immuno review, which is for immuno specifically. Dr. Ahlam taught 11th batch and potentially earlier. So when you're going through the past, the per batch one, focus on the 11th batch and what she's asking about specifically. Okay. The bulk of MSI isn't describing or explaining pathogenesis or whatever. It's mainly recall questions. Okay. Each disease has that one thing that's special about it, so you can figure the diagnosis. Don't stress it. Go over the notes I linked. I tried them. They're true. They're amazing. Okay. Pathoma, if you're still confused about something, spam questions as much as you can. Practice and past and practice too. Anki maybe. And then Alhamdulillah salame. I'm a tired girl. I really want to go sleep. Okay. And please fill out the form while you're at it. Hope you enjoyed. Please don't hesitate to contact me if you have any questions. And if I missed anything, I'm really sorry. This should be like 95% inclusive. Best of luck for your exams. See you soon. Bye.